and welcome to everybody who's come. What we'd like to do is to ask you to hold your questions unless they're clarifying ones till we're done with our talk. We've left plenty of time for questions. So, what is a myth and what is a reality about Obamacare? The Patient Protection and Affordable Care Act, otherwise fondly called Obamacare, was signed in 2010 by President Obama. What is it? A major goal of the act is to put American consumers back in charge of their health coverage and care. It puts in place comprehensive health insurance reforms that will hold insurance companies more accountable, lower health care costs, guarantee more health care coverage choices, and enhance the quality of health care for all Americans. How does it work? Well, one of the first things it's done is to expand Medicaid. Medicaid is a health care program basically for poor people in the United States. And it has expanded Medicaid for states that want federal money. Some of you may know that in the original bill, it mandated every single state had to expand Medicaid. But the Supreme Court turned that down and said it becomes optional. You'll see soon that most states have expanded Medicaid. There are subsidies to help both small businesses as well as individuals with modest incomes to purchase private health insurance. There is a new marketplace called healthcare.gov to purchase insurance by employers and individuals. There's a more level, competitive environment in terms of purchasing insurance. And the government subsidizes insurance premiums for people who are 138% to 400% of the federal poverty level. Insurance must now cover children regardless of their health problems. They cannot refuse adults health insurance because of pre-existing conditions. So for example, some insurance companies would not insure women who were pregnant. Some insurance companies would not insure you if you had cancer. It also allows people who are under age 26 to remain on their parents' health insurance plans. Insurance carriers cannot charge sicker people more money. That's what used to happen. And premiums must be fair and not discriminate by sex. Insurance premiums were much higher for women than for men because insurers figured that the women would get pregnant and would need obstetrical care, and that would be expensive. That doesn't happen anymore. There are incentives in the program to insure more workers. So if an employer has 50 or more workers, they have to provide coverage which meets minimum value and affordability standards, or else they pay $2,000 per employee as a fine. Small employers, those with less than 25 workers, get tax credits for providing coverage. Obamacare offers numerous what are called essential health benefits. So ambulatory patient services, in other words, those services that are not in the hospital, but are in outpatient hospital departments or in doctor's offices. Emergency service, they have to cover hospitalization. They have to cover maternity and newborn care. They have to cover mental health and substance use disorder services, including behavioral health treatment. Behavioral health treatment refers to psychotherapy and talk therapy. So in addition to providing drugs, they have to provide the behavioral health treatment. The insurance has to cover prescription drugs, both rehabilitative and what are called habilitative services and devices. Habilitative services basically help people survive by being able to do their activities of daily living. So it helps people keep those functions learn or improve their skills. So it would cover things like walkers, it would cover railings in households and outside on steps and things like that, special devices for doors to help make them easier to open. It has to cover laboratory services, preventive and wellness services, and chronic disease management, and pediatric services, including oral care, in other words, dental care, and vision care. Obamacare really stresses prevention and avoiding disease. And the premise is, if you catch things early, it will cost less to treat them. No co-payments or deductibles are allowed for immunizations and screening for many illnesses, everything from cancer to depression to checkups. It also seeks to expand the pool of physicians who are primary care doctors, who are not specialists. So that includes family practitioners, internists, OBGYNs, because they cost less than specialty care, and they can handle about 90% of patients' problems. So let's talk about some of the myths and the realities, and I'll go through a few of them, and then Alan will pick up. There's a myth that the Affordable Care Act will kill jobs. There's a fear that employers would switch to part-time workers so they wouldn't have to provide health insurance, because the law covers basically workers who work a certain number of hours a week, and if you work less than that, you don't get covered. The reality is not clear. The argument was premised that if a single employer has to raise wages in order to include health care benefits, the cost will be too high, and the employer will lose money. This is not the same if all employers must raise wages. And so it's kind of similar to what we see in terms of the minimum wage arguments and why those are beneficial. But there's absolutely no evidence thus far that there was a major shift to part-time workers to get around having to provide health insurance. And our unemployment rate, basically, if you can see, is very low. It's, as of August 2016, it's slightly below 5%. So the notion that after Obamacare was passed in 2010, that unemployment rates would soar is just simply not true. How much of that, we can account for by Obamacare is a question. Another myth, that the Affordable Care Act will not improve the healthcare system. Summers et al. For the years 2012 to 2015 found a clear downward trend among people reporting their health as only fair or poor. Analyses of subsamples by race and ethnicity and by states that participated in the Medicaid expansion program versus those did not reveal broad gains following the initial enrollment period. So once healthcare.gov was started, the health exchange program, once states expanded their Medicaid, once employers started offering health insurance, they found that fewer people than before were saying that their health was fair or poor. They also determined that compared to Texas, which did not expand Medicaid, Medicaid expansions in Kentucky and Arkansas led to major improvements in access to primary care and medications, affordability of care, utilization of preventive services, care for chronic conditions, and self-reported quality of health and care. Another myth, that the number of uninsured will not decline. There's fear that people would just be so fritz by the problems on the website, healthcare.gov, that they wouldn't sign up. But the reality is that in essence, the number insured dramatically declined. This graph shows the number who were uninsured, and then shows it by states who expanded Medicaid or did not. And this is by age. So the first blue bar is ages 18 to 20 to 35. The second bar, the purple one, is 36 to 44, and the 55 to 64-year-olds are the yellow. Now, we generally don't talk about people who are 65 and over because almost 100% of them receive Medicare, so they have full health care insurance. But you can see, you can see basically, if you look at the first set in 2013 and compare it to the second set of bars in 2014 for every single age group, the number uninsured went down. If you compare those states who expanded, which are in these graphs, versus those who didn't expand, you see between 2013 and 2014, again, drops. There were drops also in the non-Medicaid expansion states. However, notice that there are still lots of people in those states who are uninsured. We know that uninsured rates were also fell among people who were not rich. So this graph shows the total number of uninsured by the year that in question, and the month. So it starts in July 13, and then the 14, August through June, and March through May 15, and February through April 16. And you see that really before the program was fully up and running, we have more people who were uninsured, and as time went on, it declined. We see these data talk about the percent of the federal poverty level, and for those of you who are wondering, if you're a single person, and this is in 2015, and you earned less than $11,770, you were below the poverty level. So what's interesting is also when you look at just the total population, the Census Bureau just came out with the report that the number of uninsured in 2014 dropped by 8.8 million people. So in 2013, which is the first major year when the program went into effect, we had 41.1 million uninsured people in the U.S. By 2014, it had dropped to 32.3 million. So it went from 13.3% uninsured in 2013 for the whole population to 10.4% in 2014. So that's a really significant drop. And basically, in reality, the number of people who are uninsured has dramatically declined. Yes?
Is there a reason for the uptick in the 100% that it started going up in 15 and 16?
That really has to do with the states that didn't expand Medicaid. So those people were a particular risk in those particular states, I believe. Do you?
No, that's correct.
Okay.
We'll talk a little bit more about that.
Okay, your turn.
My turn. This kind of collaboration is evidence that if you manage to work with people who are smarter than you are, You can get a lot of publications and a lot of research grants, so I've been very fortunate with that. In the original Obamacare, the idea was to give the states terrific incentives to expand Medicaid. Medicaid is basically a matching program. It's very hard to study Medicaid because there's 51 different programs, as opposed to Medicare where there's one. Medicaid was, and it's based on a match, and the match has typically been between $1 and $2 for every dollar that the state puts in, which essentially cuts the cost of Medicare of medical care by almost 50%. Well, the matches that were given for Obamacare, were on the order of 8 or 9 to 1. So, in a sense, they were cutting the cost of this Medicaid rather, by 90% for several years. Anybody who knows me will understand how I feel about Texas, and you can see that one of the issues with the increase of health care is that 2 of the 3 biggest states, Texas and Florida, chose essentially to forego an 8 to 9 to 1 match based on their premise that several years down the road the match might go away. Other states such as California or Florida, California, New York, and in fact states run by Republican governors, including Ohio and Michigan, chose to take the match. I'll leave it to you to decide how some of these decisions were made. So there's been some major expansions, even in states that we typically view as being more politically conservative, including, if I can find this here, Kentucky, although the recently elected governor of Kentucky is trying to roll back everything that was put there. Arkansas has managed to do that. So indeed, you've had, say, Arizona, the bastion of progressive thinking, Arizona, has also managed to increase their Medicaid expansion. You can see that here's a measure of the percentage that are uninsured by state. I'm always a little wary about county maps because you get to places like Nevada, where you have more coyotes than people in some of these counties, but what you see here is that particularly in the northeast U.S., for the most part, the percentage uninsured by state has gone down dramatically. I was talking about Arkansas before, and if you compare Arkansas with the neighboring states here, Arkansas is over there, you can see that Arkansas's rate of uninsurance is considerably less than the surrounding states. So that's what you have. We've got some comparative pictures there that again show, so you have 2013, you have 2014, you have 2015. I'm not sure exactly what this is all about, but it is Texas, so I don't care much. Access to health care under the Affordable Care Act will be difficult. What you had, of course, is you had the rollout. You had the rollout of the healthcare exchanges, and you had the rollout of Medicaid. And most objective observers felt that it probably, given some of the issues that came, it probably would have been good to have postponed it 3 to 6 months, but you couldn't do that politically. So it came out like any new set of websites. They didn't work very well. And that's what you had. Ensure competition. If you want to think about the exchanges, think about orbits for health insurance. That would be basically the kind of thing you would be able to get on there, and you'd have a lot of different insurers that would be advertising. So the question is, would you get insure competition in the marketplaces? In general, yes. In general, more than half of the people who were enrolled in the marketplace said they had the option of choosing a less expensive plan. Sometimes they chose less expensive and less coverage. And the opponent sees on that and say, well, you see, it didn't work. Most economists who have studied a lot of different welfare plans will sometimes determine that the opportunity to spend less on something that's smaller means you can spend more of your money on other things. And people have seen this having to do with food programs and with housing programs and the like. Across all marketplace plans, we see that over 3/4 of the enrollees were very or somewhat satisfied with doctors covered by insurance, and among these adults, 64% reported that their plans have some or all of the doctors they want. And again, those of us who have dealt with the various insurers that we have here at Wayne State, particularly if you switch, sometimes you don't get the doctors that you want either. So this is not unique to Obamacare. 4 of 5 adults with new marketplace coverage are satisfied. We got some bars there. The dark green is very satisfied. The light green is somewhat satisfied. Or if you were like my Aunt Betty of blessed memory, never satisfied. But that was long before Obamacare. What do we have here? Does your current insurance include all, some, or none of the doctors you wanted? This was Aunt Betty over here. But again, there seems to have been a general type of coverage. What you sometimes have, and again, if you do looking at this at the county-wide level, there are 3,000 counties in the United States, and probably 1/4 of them have more coyotes than people. So they can't really, you're not going to have a large base to work with there. But if you look where most of the people live, you're finding that the coverage seems to work pretty well. 3 of 5 adults with Medicaid or marketplace coverage found it very, trying to find a new primary care doctor, found it very or somewhat easy to do, and more than half waited 2 weeks or less to see them. All right, so again, there seems to have been pretty good access. It's hard necessarily to do counterfactuals. It's hard to say exactly what would have happened if we hadn't passed Obamacare, but certainly the predictions of inability of doctors not accepting it, or inability to find a new doctor seem not to have been a problem. Costs will rise, the myth, or at least the story, costs will rise under the Affordable Care Act. Yep, they have. It's hard to insure 18 to 20 million more people without it costing more. I mean, now, uninsured does not mean no care. But very often, in fact, uninsured people get care in the most expensive places, emergency rooms, where they're getting very capital intensive care, very expensive care, often for conditions that don't need that kind of care. There was a major increase in enrollment. The increase in enrollment grew faster than the economy. We've seen in the past that enrollment increases lead to expenditure increases. So, yep, it did. It did. Yes, I mean, there was some unrealistic things that would say, well, we're going to have this new system and everything's going to be more efficient. And again, economists can be real buzzkills on that. How exactly are you going to insure 18 million more people without, or 20 million more people, or whatever it is, without it costing more? And we were right about that. There were some transitions to managed care. And in the transition to what's called managed care Medicaid, they gave some incentives there, and these were going to also increase the cost. So the cost did rise. Kathy Schoen argues that a number of Affordable Care Act reforms have likely contributed to the slowdown in healthcare spending growth. They tightened provider payment, they reduced some payments to hospitals and such. This is research that's ongoing. What's been happening is that the share of medical expenditures, of health-related expenditures in the U.S. economy is up right now about 17.5% or 18%, which is 6 percentage points higher than anywhere else in the world. That's a different lecture to talk about. And again, it's hard to do a counterfactual on that. And periodically it waxes and wanes. After a couple of years of not going up much, it seems to have started going up some more, and people are trying to guess why, and nobody's quite sure. High public levels of public dissatisfaction with the Affordable Care Act. Again, if you take a look at some of these measures, two places, by the way, to get good measures on the Affordable Care Act. They tend to be a little more sympathetic, but they have pretty good measures. One is called the Kaiser Family Foundation, KFF.org. The other is called the Commonwealth Fund, and such. And these are good places to get up-to-date stuff because the data are always coming in. What we see is that the dark green is very satisfied, the light green is somewhat satisfied, and again, basically there seems to be a pretty good level of satisfaction in terms of the healthcare system. What's interesting to do, we don't have these here, is to actually look at levels of satisfaction in several countries around the world. Commonwealth Foundation does these surveys that you have. And for example, you hear people talking about how people in Canada or people in the UK are always waiting for coverage and the like. And I always tell a story about playing golf with a fellow from Canada, and he said, boy, it's good to be playing golf. I haven't played golf in 18 months. I said, really, what happened? He says, I needed a hip replacement and I had to wait. I said, well, how do you feel about that? He says, well, it was free when I got it and somebody else needed it more than I did. Now, that's a certain type of attitude that you have. A lot of Americans would not put up with that. So to compare that with different places is a useful kind of comparison. 4 of 5 adults with new marketplace coverage are satisfied with the doctors and their plans. Gotta make bigger slides here. Again, dark blue is all the doctors you wanted. Light green is don't know which. This one is some of the doctors wanted, and this is Aunt Betty there. Okay, none of the doctors you wanted. My co-author, my collaborator here, took down this cartoon. If you can't read it from the back, I will read it for you. This gentleman is saying, I hate Obamacare, healthcare reform should be repealed. And she asked, well, which part, the one that ensures children aren't denied care due to a pre-existing condition? And he says, no, I like that. The part that allows kids to be covered by their parents until they're 26, he says, well, no, that's good. The part that stops insurance providers from dropping people when they get seriously sick, no, that's great. It's the other part I can't stand. And she said, well, which one is that? And he responds, the Obama part. So, you have some of that there too. All right, so bottom line, as it were, the bottom line. Generally, there's been a positive impact. Without question, the number of uninsured has gone down dramatically. Particularly during the Great Recession, it was touching at 50 million people. 50 million out of about 320 or 1 in 6. I co-author a health economics book, and for years and years, we had to say that the U.S. and South Africa were the only 2 countries that didn't have some form of universal health coverage. Then we were able to take South Africa out of it, and it should be pointed out. It should be pointed out that even under the most generous interpretation of the first Affordable Care Act legislation, they still expected to have about 18 to 20 million uninsured by 2020. Now, of course, that wasn't going to be so bad because most of them were going to be illegals, supposedly. Although, to try to figure, I mean, there are an awful lot of illegal people who in fact, illegal immigrants who have health insurance coverage. I mean, there are all kinds of stories you can tell. Sometimes you have a legal spouse who's married to an illegal spouse, and the child who was born in the U.S. is legal, so 2 of the 3 people in the household have insurance, but 2 of the 3 are illegal, or one of the 3 is illegal. So you can have that, and the point that you have to make is that even people who are in the U.S. illegally cannot be denied, for example, emergency care coverage. You know, so if an illegal resident gets hit by a bus, they get treated. You know, and then you have there's a whole host of issues. When you talk about foreign workers, foreign students, and the like, many of our GTAs in our department are foreign residents, and they have health care coverage. You know, so it's not clear exactly how all that works. Accessibility has gone up, coverage has gone up, satisfaction certainly has not plummeted, and it seems to be good. Quality of care, again, seems to be good. Employment impacts, unemployment rate is 4.9% now, which has been certainly a good measure of the unemployment rate. I'm aware that something as complicated as unemployment, it's very difficult to describe it with one dimension. You know, there are some people are working 20 hours and they'd like to be working 40 hours. Some people are in the job that they don't like, but those problems have always been around, and a 4.9% unemployment rate is historically excellent. Bottom line, what we're not sure about, costs seem to be rising at least as much as might have been expected. The first bulge of the baby boom has kind of gone into Medicare, and you're going to see that, and that's going to be increasing costs, and Obamacare doesn't have much to do with that. The other thing is there seem to have been some issues in so-called adverse selection. So the idea has been adverse selection means that somebody who feels like they're going to need care gets insurance because they want the insurance to cover the care. An example that some people at Wayne may be familiar with is the dental care. If you come and you work at Wayne and you want to, at least when we came, you had to wait 6 months to get dental care in the insurance because they didn't want somebody to come and work to Wayne for 6 months or 9 months, get all their dental care done, and then leave. That's what's called adverse selection, because you're not getting a regular, you're not getting a random sample of the community. My co-author of the text, Miran Stano, has done some research, and he's found that there seems to be some amount of in and out of these healthcare exchanges based on needing care. Now, we could certainly get rid of that by a totally universal healthcare system, and there's some people who would have preferred that. But that's a potential issue, and depending on how big it is, it could be a big issue. It does not seem to have been a big issue thus far. So that's what we can give you. I can't imagine with this group that there aren't going to be questions, so fire away. Yeah. If you would tell us who you are.
Sure. I'm Dr. Sandra Oliver McNeil. I'm from the College of Nursing, and I'm an acute care nurse practitioner. So I've been listening with the physicians, I've been in collaborative practice about the Affordable Care Act for quite some time. But a couple questions. One, and I'm going to give you all three of them because, anyways, first one is, have they looked at physician satisfaction? Number two, have you ever looked at the amount of wait time that patients need for having procedures here in the United States? For example, the hip replacement. I just know from my parents' personal experience, it takes 9 months to get into the office, let alone getting it scheduled. And I know from working in cardiology that you can't always get everything you want in a timely fashion. If you're the acute MI, you run to the front of the list. If you're elective, it's going to be the bottom. So looking at wait times here in the U.S. in our private sector, not the VA. And then the third component is Aetna is just pulled from the exchange. And what do you guys think of that?
Basically, I'm not aware of any large studies of physician satisfaction or dissatisfaction with the Affordable Care Act. So I don't think that researchers have started to collect data yet on that particular topic. Second, there's no evidence that since the Affordable Care Act was passed, that wait times have increased, which is something that people were very worried about. And the third question about Aetna, you want to handle that?
Well, the most publicized in and outs on this were United Healthcare and Aetna, and neither of them were real big players in this from the get-go. And there's always been a fair amount of churning in these markets. Some of us will remember when the University of Michigan got into with MCare and the like, some numbers of years ago. Somebody keeps on jumping in front of you, so I want to do that. And so there's a fair amount of in and out in these markets. United Healthcare and Aetna are big players, but they haven't been big players in this one. So that's the issue. Most of the international measures of wait time, for example, would be what you had expected. People wait in Canada. People wait in the UK.
For non-emergency care.
For not, but again, one person's hip for one person hip replacement. I mean, there's a certain subjective nature to that. But again, the guy I was playing golf with from Canada said, well, somebody needed it more than he did. So the point there is, the places that have some of the places that have some of the smallest wait times, in a sense, are a lot of the places that have systems like we do. That's kind of the Central European model: Austria, Germany, Belgium, and the like, that have had more, that have not necessarily had single payer, that have had some variety there. We can talk more about it, but it's a good question. And yeah.
Dave Kelton, local civil engineer, come to as many of these as possible.
Yeah.
The proof of the widespread popularity was the recent elections, where even Donald Trump agreed with almost all the tenets of it, and Bernie Sanders want to expand it. But the one thing you didn't mention was the biggest legitimate complaint was the kickbacks to special interests, that the legislation itself was flawed and full of kickbacks to special interests. Has that been measured, whether there actually has been kickbacks and certain companies have been able to...
I'm reminded of Casablanca, where the police come in and ask and announce to Claude Rains that there's gambling going on in the back room. And he says, gambling in the back room? Impossible. I mean, they say, I am not ridiculing the kind. I'm saying, yeah, this is politics, and that's, how
There's
this.
no attempt to actually measure how much.
It's
Not-
not something
not
I
yet.
do. We have some, maybe some political scientists who do. But they, you know, again, I end up coming back with the comment, you know, if you want to be offended, look at how laws and sausages are made.
But basically, what's interesting is there were going to be a number of kickbacks to the pharmaceutical companies, and they cut back on those. And so there was hues and cries from Big Pharma that you're not treating us well in Obamacare. And that's, you know, they're still earning billions of dollars. So in that case, you know, some of the benefits that they were going to offer Big Pharma were taken out of legislation.
Go ahead.
Okay.
I was wondering, like, is this a myth or reality? I was told that because, like, the Affordable Care Act, it's kind of illegal to be uninsured. Like, if you go to the hospital and you're uninsured, they can fine you or something like that. Is that true?
That's correct. It is. If you are uninsured, you can be fined, and that's why when you file your income tax these days, you need to provide proof of insurance. And at Wayne State, for example, they send records to the federal government with names of people who are insured
Was that
at the
criminal?
university.
It's not a
Just
criminal
get taxed.
offense. It's not a
Yeah.
criminal.
No,
It's not
it's-
criminal,
it's-
it's a fine.
Well,
Yeah.
it's a tax, but they can't call it a tax.
Right.
Because it was politically unpopular to call it a tax. And that, by the way, was how the Supreme Court in 2012 supported it. Because they said, you know, the example I give is that if you live somewhere and they vote to tax the population to build tennis courts, then you have to pay the tax whether you voted for it or whether you play tennis. All right, and that was, and the late Justice Scalia was furious about it, but that's what got the fifth vote from the Chief Justice, was because it was, I mean, he said you can call it anything you want, it's a tax. And so in that sense, and the idea again has to do with the adverse selection kind of story. You want to get everybody into it. Now, would a single payer plan have been easier to administer? And the answer is yep. But the private insurers pay for about a third of the health care in the United States. We spend about $3 trillion on health care, and nobody was prepared to nationalize a $1 trillion industry.
So that one source would pay for all the insurance and would cover all the insurance plans. That happens in some countries outside of the U.S., but the U.S. was not prepared to go in that direction.
Well, it was a political non-starter.
Yeah, there's
Right.
not gonna happen.
It would have
Well, the
never
insurance company's out
gone.
of business.
Yes.
Yes, I'm Dr. Gibson Sakil from the College of Nursing. My clinical background is in primary care, particularly underserved communities. So prior to the ACA, there were a number of resources that were available to uninsured persons, such as, say, the Physicians Who Care program, who would provide specialty services. Now that the ACA has come into play, a lot of those resources have dried up, yet we still have a number of people who are uninsured, even within that population of 18 to 35. If we break that down, the 18 to 24s are not significantly more insured than they were in the past. So what do you know about that population that remains uninsured and the impact of the ACA on them?
Well, one of the things is that 18 to 24-year-olds often feel that they are invulnerable. And so they feel they don't need insurance and they want to spend that money on something else. And that's not surprising. So they are, you know, some of the people who are more likely to be underinsured or uninsured under the Affordable Care Act. Many of them opt for very high kind of catastrophic plans, so that your deductible has to be well over $1,000 before your insurance will kick in, because that's a less expensive insurance plan to get, and then they have money available for other things that they'd like to do. But I'll let Alan.
No, I think that's the point. Another thing is that a lot of the 18 to 24-year-olds are now on parents' plans. I don't have good numbers on those. And again, one of the issues that you have with these is that is that because of the vesting of this at the state level, whenever you want to go out and get data, you have to get data from 51 places rather than one. But it's a good point.
And some of the changes in the plans that, that you've mentioned may be differences across states. So there may have been pass-through money for states for these programs, but the states decided instead they were going to expand Medicaid rather than fund some of these other programs. I don't honestly know the story behind that. I'm sorry.
That's a good question. Yeah.
But it is a good question.
Yeah.
I've always been kind of surprised how angry the Republicans are about the Obamacare. I mean, given most of the positive things, I can understand like abortion, how they're crazy about abortion, because that really gets emotional. But why are they so upset still?
Well,
about this thing?
if you parse the language, their current nominee really isn't seriously talking much about Obamacare.
But he says he's repeal it.
Well, but he's not.
He's not the most specific.
Well, I'm just saying that it's really hard for a politician to take away something that millions of people already have. It's bad politics, and so again, if you again, this is not what I do for a living, but if you study the nuances, that's what you would get. It's in a certain sense, again, one gets the sense that that when they proposed this, the idea was, look, this is something that Mitt Romney had done in Massachusetts. Romney was a Republican. It had passed in Massachusetts. You giving this, it was better than the Hillary Commission of 93, 94, which was all messed up with the private insurers. The private insurers liked it, and I think it was really a surprise that the opposition party was so dead set against it. But again, if you parse some of the politics that's going on now, it doesn't seem that it doesn't seem that it's going to go away. Yeah.
Hi.
I want to piggyback off of a couple of questions. Two quick questions. What position did insurance companies take on Obamacare during the period in which the legislation was drafted? And my second question is, in terms of the bottom line, in what ways have private insurance companies benefited, been hurt, or remain unaffected by this policy? So,
I think again, when they passed, for years and years and years, doctors, physicians were against Medicare because they viewed it as socialized medicine, and this was socialism, and of course the next step after socialism was communism.
Russia,
I think in this sense here, after again 93, 94, when the Hillary Commission was dead in the water, you got involved with this, and certainly the Massachusetts plan was done hand in glove with the insurers. Now, in order to going back to Medicare, in order to get the doctors to buy, and the hospitals to buy in, they basically let them determine what they were charging, and that lasted for another 15 to 20 years. And so, the bottom line there is, my impression is that the insurers viewed this as a way to get, to make sure that they got their share. And if you think about it, it actually led to increased enrollment.
right.
Increased enrollment of, in many ways, a lot of reasonably
people.
healthy people.
Right.
You had a second question.
You got it.
I got it.
Yep.
I got it.
Yep.
The doctors did get pay cuts.
Doctors are always complaining about pay cuts. I mean, they had been trying to cut physicians' pay under what SGR. I'm forgetting what a term that they basically threw it out. But there has been they have been complaining about that. But medical school enrollments are still stable and the like. Yeah.
These myths that you addressed, were these concerns that arose out of general consensus, or are they myths that are presented more like by a certain party affiliation or interpretations of the act itself?
Well, some of each. And there's always there's a reasonable discussion to be had about when you mandate some kinds of care. And particularly if it's going to, now what we had here is an individual mandate to get care, but many individuals are getting their mandated care through the workplace. And if you're going to be doing it through the workplace, this is going to be an increased cost, and very often the issue is who's going to pay the cost. So in that sense, there's certainly legitimate questions to be asked. These are the same kind of questions to be asked about living wages. If you increase the living wage to $15 an hour, is there going to be unemployment? And there aren't many economists who would argue there isn't going to be some collateral unemployment because it's going to cost more. The issue is then are the people going to be paid more? So in that sense, that's a, some of these myths are legitimate. Another kind of myth would be, there was one an interesting one that says with all these newly insured people, you're going to have a massive shortage of doctors. And a lot of that is based on some, I use the term manpower because that's the kind of planning models of what you're going to need, and those estimates are all over the place. So I think that there's also some the death panel crap and everything else, which was nonsense, and nobody is seriously paying attention to that. But the idea, but again, there are legitimate concerns. And again, certainly the people who are concerned about the costs, as I said, the Obamacare legislation was really kind of wussy about that kind of stuff. They didn't have any good hard cost-cutting kinds of things there. And we're going to study it a lot, and that's basically what it came out to, and they're still studying it.
So a lot of these myths, some of them are raised, by researchers and academics. They aren't necessarily all, Republican generated. Some of them are from independents and Democrats as well. They're basically some logical questions that you want to address when you get to this kind of change, in society and what's going on. So that's something to keep in mind.
I have a comment and a question.
What's your name?
Kim Jaffe, Associate Professor, School of Social Work. One is that there's a wonderful front line called Obama's Deal that for talking about the political aspects of the Affordable Care Act, really well depicted in that, and some of that is still, part of the debate. My question to you two is, the people who study this, are you proponents of a single payer system? I don't know if that's a fair question, but.
Did you vote for Bernie Sanders?
No, I didn't. In many ways it would be simpler. On the other hand, the perfect is the enemy of the good. And it was very clear that you weren't going to get that. And I guess in that sense, they had to make, for people my age, kind of a Rube Goldberg sort of contraption to make this thing work. And candidly, I always thought that if it hadn't been for Harry Reid and Nancy Pelosi, even this wouldn't have gone through. Again, there would be certain things would be a lot simpler with a single payer, but again, I prefer to have what we have here than not have anything. Yes.
Can I go back to the Florida and Texas opting out?
Yes.
What is exactly is the practical consequence of actions those states have taken with regard to?
There are much higher rates of uninsured people in Florida and Texas than anywhere else. Texas has 26 million people, all right? Because Texas has not done the Medicaid, compared with, let's say, New Mexico. One of my students did a Texas-New Mexico comparison. It was kind of a nice comparison because they're both in the Southwest. They both have large Latino populations and the like. And now, of course, New Mexico is a fraction of the size of Texas. But you have two states with a total of somewhere around 45 to 50 million people that have chosen, 45 to 50 million people is as big as most of the countries in the world, and they've decided not to expand Medicaid. So you're talking about hundreds of thousands of people that don't have expanded Medicaid.
And basically, they're gonna have more health problems in those two states because people don't have insurance and therefore lack access to adequate health care.
Hi, my name is Jonathan Lumuge, and I am with the Center for Urban Studies.
Uh-huh.
And one of the findings that you reported was about rising costs. And I want to find out, or if you could elaborate a bit, whether it's the general cost of healthcare is rising, because I know that one of the objectives of the Affordable Healthcare Act is to lower healthcare costs overall. As more people use primary healthcare and people focus on prevention, it's expected to lower healthcare costs overall. So the rising costs that you found, is it about specific healthcare services or overall?
Well, it's an interesting question. For example, one of the things that's happened because of Obamacare is that contraceptive care is free. So the birth rate is going down in the United States. And so costs of maternity care and prenatal care have dropped as a result of women being able to get contraception without cost. So you really have to look at the sectors per se. I mean, there have been various proposals in Obamacare to try to limit the rise in healthcare costs. We haven't gotten to that stage yet in terms of implementing those kinds of changes. But certainly, I would argue, at least in terms of offering preventive care without cost, that we're going to see a drop in the cost of conditions that would have cost a lot because we weren't taking preventive action. So it's a very complicated, set of questions and data to try to analyze. And, since this really didn't get implemented till, 2013, 2014, we need a time span to kind of understand what's going on.
I think we're getting on towards time. We'd be glad to sit and chat with anybody who wants to, anybody else who wants to ask questions.
And any of the Central Pre-Meds who need your form signed, come on up.
Thank you for coming.